He's going to give us a presentation on transplant imaging.
Thank you very much for the introduction. So, good afternoon everyone. I am Dr. Nitin Ghonge from Indraprastha Apollo Hospital at New Delhi in India. So, I am going to talk about the transplant imaging and a brief update about liver and renal transplant from our hospital, which is doing significant number of these cases. And at the outset, I would like to convey my sincere thanks to the organizing committee, the organizers, particularly Dr. Tarek and Dr. McGinty, to invite me to this esteemed forum. So as you know, the radiology is advancing really fast, and this yesterday my trip to the Egypt Museum Cairo gave me opportunity to go through these fantastic images of the ancient Egyptian mummies, and this further emphasizes how the radiology can have impact on diverse fields in our day-to-day life. So back in India, in sync with other fields, other topics, other areas, the healthcare as well as medical imaging is progressing very fast and is evolving and contributing to the betterment of patients, the betterment of the treatment of the disease in significant ways. The transplant imaging in India started way back in almost the same time when the first cardiac transplant was performed in South Africa as early as 1967, and this was the article we had in our National Radiology Journal, which was only dedicated to transplant imaging. In India, the transplant surgery is regulated by this act called Transplantation of Human Organs Act, and there is a national registry where all the details, all the transplant surgeries are listed, whether it is done in a government or a private setup. But there is a huge gap. There is a lot of concerns and challenges which we are facing right now because of the significant gap between the demand and the supply. When we talk about the numbers between the liver transplant which are actually being done and what is required, and the same applies to the liver transplant, we can see a significant gap. So there is still a lot more to be done because of the huge population India has, and because of the large number of patients who need liver and renal transplants. So just to give you a perspective, these are the numbers of transplants, renal transplant more than 8,000, and more number of liver transplants more than 3,000 are done in last almost more than 10 years at our hospital itself. So now coming to the renal transplant, I don't know whether the audience are actually doing liver transplant imaging by themselves, but I am going to give an overview and few specific points about how we approach and how we perform the transplant imaging at our place. If it is an open nephrectomy, then the details are not much required. But if we are doing a laparoscopic donor nephrectomy, that is LDN, then you need a comprehensive assessment to decide whether it is a fit patient, fit donor. So fitness to donate is assessed. And second is the regional anatomy, whether the surgical approach should be, what should be the correct surgical approach because in a laparoscopic surgery, there is a limited window and you need to be very sure about what exactly is the anatomy before the surgery itself. Like if it is a single renal artery or double renal arteries, that is the most basic thing. And the distance between the two arteries, like they are closely placed on right side and widely placed on the left side. If they are closely placed, then the surgeon can afford to have a single anastomosis between the artery and the artery. If they are widely placed, then it has to have a two separate anastomosis, which increases the time as well as the potential complications. This is an operative bench image where you can see a wedge-shaped infarct in the upper pole. This happened when a radiologist fails to convey that the upper polar accessory artery is there and the surgeon fails to salvage that artery, then this is a complication which can happen and should be avoided because of the good preoperative donor assessment. Now, very important is to look at the arterial vascular pedicle, which should be at least 10 mm for a good harvesting. So this is from the site of origin and the first branching on both sides, right, as well as left side. So this is how you calculate the arterial pedicle on each side. Similarly, talking about the venous vascular pedicle, we can see the last confluence site and up to the site of drainage into the IVC. Similarly, on the left side, so this is how we calculate the pedicle on the right as well as the left side. On the left side, we can see the pedicle is quite long and there is usually not a concern, but the pedicle length of the vein is important on the right side. Very important for the radiologist to know, this is an important triangle called golden triangle. This is the renal vein, this is the gonadal vein, and this is the lower pole of the left kidney. So surgeon never dissects in this golden triangle because this triangle has to be saved. There is always a ligation in the lower part of the triangle so as to save the ureteric artery. Ureteric artery can arise from a small twig from a lower polar renal artery or from the main renal artery, and therefore it is difficult for the surgeon to dissect this area. So it is therefore important for the radiologist to specifically look at any of the tiny artery which is supplying the upper part of the ureter or the lower pole of the kidney, and accordingly the surgeon will only clamp the area below the origin of this artery, and therefore ureteric supply will be maintained in a harvested kidney. Now very important, as a radiologist we need to know that during the surgery, if the vessel, if the artery is more than 5 mm, then surgeon cannot apply the cautery. If it is more than 5 mm, then clipping, vascular clipping is to be done. So on the right side, the gonadal vein directly drains into the IVC, so not a problem with the right-sided harvesting. But on the left side, we can see several veins like left adrenal vein, we can see the left gonadal vein, and we can see the corresponding operative photographs which drain into the left renal vein. So we need to look at the site of insertion, communication with the gonadal, with the renal vein, and whether it is more than 5 mm. If it is less than 5 mm, then it is all right and the surgeon can apply the cautery. But if it is more than 5 mm, then ligation is important. That should be included in the report. Another vascular communication is the left lumbar vein. We can see the lumbar vein which is much more than 5 mm and is connecting the left renal vein. So this should be communicated to the surgeon in our report. Then again, apart from this large, you can see the large communication of a portosystemic dilated tortuous collateral running along the surface of the kidney and communicating with the left renal vein. So this should always be communicated because this is very large and should be properly ligated, identified and ligated so as to avoid the bleeding. Because once there is bleeding, there will be complete obscuration of the operative field and it will become a difficult surgery. So this is how in a laparoscopic donor harvesting of the kidney, we need to convey all these important points as we just mentioned in a subjective as well as objective points so that the harvesting becomes easier and more operative time is less, complications are minimized, and surgeon is aware of all the important surgical details. Now coming to the post-transplant assessment of a transplant kidney, this is how we follow this flow chart. The ultrasound, including B mode, color Doppler, and spectral Doppler, forms the basic point, very basic, of assessment of the renal donor after the transplant is already done. And depending on the anatomical complications, whether functional complication, vascular complication, non-contrast MRI or CT, depending upon whether the contrast functions are maintained or not, renal functions are maintained or not, is done. But the main important thing is the ultrasound and the Doppler study. Like this is an example. We can see that aneurysm was diagnosed on Doppler and which can be further evaluated on CT angiography because the renal function was normal. But in this another patient, you can see the renal function was not normal. So we have done a non-contrast MR angiography which can nicely show this narrow neck of the aneurysm and without any risk of risk to the kidneys which are already compromised. And we can see here is another important complication of a renal allograft, which is acute cortical necrosis, and we can see this curvilinear serpiginous areas of T2 dark signal with poor assessment, poor enhancement on post-contrast study with multiple areas of restricted diffusion in the ADC image. MR urography is useful to look at the urothelial complications, like we can see the urothelial wall thickening and edema, and we can see the urinema formation, leak of positive contrast into the peritoneal cavity. So urinary complications are important. Then very important in our setup, because these patients are immunocompromised, the fungal ball. Fungal complications are very, very common in these patients because of multiple reasons, because of the low immune status, and we can see echogenic appearance or at times dark appearance. So this fungal ball in a kidney, in a renal allograft can have a dark or a bright signal on ultrasound, as we can see, and on MRI we can characteristically see this blooming artifacts, blooming appearance on SWI or susceptibility weighted images, which doesn't show enhancement and shows variable signal on T2 depending on the degree of inspissation. So this renal fungal ball is a very important complication, which can also be seen in urinary bladder, as we can see in a transplant recipient, and we can see the cholesterol crystal. This is not vascularity, this is cholesterol crystal in a fungal ball in a urinary bladder, and the same can be seen in a native kidney, which is small shrunken native kidney, but because of the poor immunity, the fungal ball is now seen in the native kidney. Then other neoplastic complications can include squamous cell carcinoma at the vesico-ureteric junction, as we can see, or it can be a renal allograft. That transitional TCC, transitional cell carcinoma, can involve the renal allograft also at times. Then talking about allograft dysfunction, we can differentiate between stable, acute and chronic allograft dysfunction depending on the shear wave sonoelastography, the parenchymal stiffness, as the study and the paper we have published a few years back is able to differentiate between these three conditions, like normal versus acute versus chronic allograft dysfunction. And this is another paper we have done using the bold and the diffusion weighted MRI to differentiate between normal, acute and chronic allograft, and there is now a lot of publications which talks about the role and relevance of functional MRI in renal allograft assessment. Very important is everyone knows the Doppler is the modality of choice till very long time, but there is always a problem to differentiate between the acute rejection and the acute tubular necrosis. But with the help of MP MRI, with the help of bold MRI, we know that acute rejection has an increased oxygenation and therefore decrease in the R2 star values. While on the other hand, ATN or acute tubular necrosis will have an increase in the R2 star value. So this is something which is very useful and can replace Doppler in future, particularly for AR versus ATN. Then coming to the liver transplant, renal transplant is relatively easy, but liver transplant is difficult because you only have a single liver, so it has to be a split. And in India, there are hardly any cadaveric donors. In Western countries, it is mainly cadaveric transplant, which is easier. But in India, we have usually living donor liver transplant, what is called as LDLT, where you need to decide the fitness of donation, whether the liver has low fat quantification, volumetry is optimal, and anatomy is suitable. So this is a difficult, and therefore radiologist has a lot of role to play to decide whether the patient can be subjected and be treated as a liver donor or not. In adult LDLT, this is the transaction plane where right hemihepatectomy is done and only the left side is left in the donor. So this middle hepatic vein is also left in the donor, and this part on the right side is completely taken out and is given to the recipient. In pediatric cases, it is only the left lateral sectionectomy where harvested segments are only 2 and 3. So this is the basic difference between adult and the pediatric LDLT. Very important is to decide whether the patient can be chosen as a donor or not. CT density based on whether attenuation is less than 50, LAI comparison with the spleen, and MR spectroscopy fat fraction of more than 10. Then patient is subjected to liver biopsy. If it is fat proportion is more than 30%, then outrightly the patient cannot be a donor, and the family has to find another donor. So this is how the fat fraction quantification based on CT as well as MR spectroscopy helps us to decide whether the patient can be fit as a donor or not. Then very important is the liver volumetry. The basic criteria whether the patient can be a fit donor or not is to compare the graft versus recipient weight ratio. The donor CT scan is done and the harvested right segment is measured, volume is measured, and the recipient ka weight is measured, and you calculate the ratio. If this ratio is more than 0.8, only then this can be a fit donor. Second is the donor remnant volume. the donor should at least have 30% of the total liver. So that is important. If it doesn't fit, then he cannot be a donor. So according to this volumetry, the surgeon can mark the liver on the intraoperative operative table, and accordingly the incision plane is drawn along the middle hepatic vein, leaving MHV with the donor. Then multiple arterial anatomical details. First is the hepatic artery, which is very important to define, because only then the donor workup is complete, and accordingly the surgeon can decide the operative technique. Like the most important artery is the key point is the preservation of the segment 4 artery, because segment 4 artery is the key. If it is arising like this, in this example, in the first example, we can see the arteries arising from the left hepatic artery. So this is all right. But here in this, we can see the left hepatic artery, the segment 4 arteries arising from the right hepatic artery. So this is an important variation, and these variable origins are all known, and therefore this is the role of donor workup. Then coming to the all these variations help in deciding whether the anatomy is favorable or not. Like here in this image, we can see the segment 4. This is the segment 4 artery, which is arising from the sectoral part of the right hepatic artery. While here we can see a accessory artery to segment 6 arising from the common hepatic artery. While here we can see the replaced right hepatic artery arising from the SMA. So this example is very good because this is a long artery and anastomosis is easy to make. This is also acceptable, but here there will be need for 2 different anastomoses. So thrombotic risk is more. But here in this part, in this example, we can see the anterior sectoral artery is arising from the distal part of left hepatic artery and is also giving feeders to the parenchyma. So this anatomy is not acceptable for the surgeon, and that this patient cannot be a donor at all. Similarly, for the portal venous anatomy, we know that this is the conventional variation, normal anatomy. This is the line of incision, and this is acceptable anatomy, favorable anatomy. But if it is trifurcation like this, then this is the surgical plane. This is also acceptable. Here we can see the extra parenchymal origin of the right anterior portal vein from the left portal vein. So this is also acceptable because this is extra parenchymal. But here it is intraparenchymal branching. So this is not acceptable because surgeon cannot remove this artery, and there will be problem of graft survival and regeneration. Therefore, this is not acceptable, and accordingly, this patient cannot be a donor. So these are the important points where finer details about the hepatic vein, hepatic artery, portal vein is important. Like this is a accessory hepatic vein carrying blood from segment 6 and directly joining the IVC. While this is another example where this is the incision plane, and this is the segment 5 and segment 6 artery, and they have to, on a backbench surgery, the surgeon has to join both the arteries, use a portal venous graft, and join this with the recipient IVC. So this is, therefore, these information should all be clear, and presence of any accessory artery should be communicated, because the more will be the number of anastomosis depending on the accessory arteries. Again, bile duct is important. Whenever reporting these patients, the radiologist should be aware of the operative technique, whether the single duct was anastomosed, whether the double ducts were anastomosed. Only then he will be able to look at the complications accordingly. Like this is an example where we can see the stricture. Bile duct is stricture. This is the anastomotic site. We can expect some degree of constriction, but here it is complete constriction. Elevated liver enzymes, dilatation of the central ducts, and therefore we can see the intervention was done, wire was guided across the stenotic segment, and the stent was placed to treat this patient with anastomotic site stricture. Another example, large area of biloma at the anastomotic site because of the bile leak at the anastomotic site, which is fairly common, which may or may not require surgery or stenting. This is another example where we can see hepatic artery thrombosis, large area of parenchymal necrosis in the liver graft, and we can see this is the area. This is the artery seen on day 2 of surgery. We can see some narrowing at the anastomotic site, which is acceptable, which is all right. But on day 7, we don't see the artery at all because of the hepatic artery thrombosis or HAT. Then we can see At times, because of the variant anatomy, the surgeon can directly create a aortohepatic surgical conduit. So this is on day 1. This is normally functioning a graft from the aorta directly entering the liver graft. This was all right on day 1, but on day 5 you can see the complete stump. There is large hematoma at the site, and then this is complete occlusion of the graft on day 5. Again, hepatic vein thrombosis and can show consequent changes in the parenchyma. At times, portal venous thrombosis can also be seen, as we can see in these images. At times, we can see because of the Roux-en-Y hepaticojejunostomy, the connection between the CBD is created using a Roux-en-Y hepaticojejunostomy, and at times there can be GI bleed. So GI bleed is an important challenge for a radiologist. Very important is to look for the plain scan without any contrast, to look at the hematoma, the site of hematoma, and then look for the blush of contrast. We can see the blush of contrast at this site because of the anastomotic site bleed at the jejunal anastomosis. Then this is the cut surface of liver. Another patient, we can see a large hematoma, bright on NCCT, and then we can see this ooze of contrast. So this is the ooze of contrast. The same thing is seen on MIP image in a better way. And this is the site of leak. The venous ooze is happening at the cut surface of the liver graft. So this is another example of a GI bleed. Bleed at the liver cut surface. Then talking about there are a lot of, because of the poor immune status, there are a lot of systemic complications in a recipient, like lungs. Pneumocystis jirovecii is a quite common complication. Another is a CMV infection with ground glass haze, as we can see in this example. But in our setup, we most commonly see tubercular bronchiolitis. A typical example of is shown here with tree in bud appearance or infective bronchiolitis or tubercular bronchiolitis because of the poor immunity. Very important are the fungal infections which can be seen in lung with cavitary nodules with with large area of cavitation surrounded by halo. So halo sign as well as reverse halo sign are both seen very commonly in fungal infections in the lung, which is very, very common in patients with who are transplant recipient. Again, same, this is a patient who also had lesions in the liver. The fungal granulomas in the liver are also seen in the same patient. Then brain is another important site where we often encounter fungal lesions, but very important is to differentiate between the tubercular versus fungal in the brain, because both are common in our setup, and the key is to look at the wall and the core of the lesion. So this is an example where we can see the contrast ring enhancing lesion, but the key is the diffusion weighted images. In the central, the core of the lesion doesn't show restricted diffusion in a fungal lesion, but in a tubercular lesion, the core always shows restricted diffusion. So in a fungal lesion, the core is not showing restricted diffusion, only the wall is showing restricted diffusion and enhancement, and the papillary projections, dot areas are papillary projections. This is showing restricted diffusion, that means this is fungal lesion. In a tubercular lesion, the wall doesn't show restricted diffusion, only the core shows restricted diffusion, and there are no papillary projections in a tubercular lesion. So this is very important to differentiate fungal versus tubercular. Another complication in the brain include PRES or posterior reversible encephalopathy syndrome, which is unique posterior distribution brain vasogenic edema. It is reversible, and at times it usually doesn't show restricted diffusion, but at times it should be there, it may be there, but often reverse. And there is always a difference in the pattern of renal transplant recipient versus liver transplant recipient in terms of PRES, because in renal it is always late onset, it always usually has hypertension, and it usually has less brain edema. Then additional complications like lymphoproliferative disease is also common in transplant recipient because of the immune suppression, and the commonest site are lymph nodes, like we can see a large lymph nodal mass here in this patient with renal transplant in right iliac fossa. Well, this another example is also on biopsy was found to be a lymphoproliferative disease in a temporal lobe in the brain on the left side, as we can see as a enhancing lesion with vasogenic edema. Additional sites like bowel, this is another example, right iliac fossa, we can see that renal allograft. We can see significant thickening of the ileal wall thickening without obstruction, which is quite typical of lymphoma. We can see the ileal wall thickening, and at the same time we can see multiple liver lesions here. So this is characteristically because of the PTLD, which was also found on biopsy. The patient also had these lesions or bullseye appearance this lesions, dark T2 dark lesions, with one lesion which was quite large, so because of the post-transplant lymphoproliferative disorder. Additional complications also include sclerosing encapsulating peritonitis. Because of the lot of bowel handling during the liver transplant, at times there is sclerosis, inflammation in the peritoneal, and it leads to obstruction in the bowel loops, and this is at times requires surgery, at times can be managed without any surgery also. Another important complication is the infective one in a bowel, that is pseudomembranous colitis, and we can see this gross thickening of the bowel mucosal folds. We can see particularly in the rectosigmoid colon, the wall is quite thickened, and we can see the contrast in between what is called as accordion sign, the musical instrument accordion. So this looks like a accordion sign, which is characteristic of pseudomembranous colitis and is not uncommon in a transplant recipient. Additional complications in the muscles and bones are also known, like myositis or pyomyositis. We can see a muscle abscess in a thigh muscle, and then because of the use of steroids for long time, these patients are particularly prone or vulnerable to avascular necrosis of femoral head, which is at times quite problematic for the patient. So these are also known in patients with transplant recipients. So to summarize, renal and liver transplantation are increasingly being done all over the globe, and clinical radiology is now a key member of the multidisciplinary team, and the treatment planning, the transplant planning is just not possible without radiology, and it is required for pre-transplant donor workup, pre-transplant recipient evaluation also, like to look at the iliac arteries before transplanting the kidneys in the right iliac fossa. We need to assess the recipient iliac artery, whether the right artery is more atherosclerotic or the left, so we would prefer the left-sided one so as to make a healthier anastomosis. Post-transplant surveillance is very important to look at the early complications, to diagnose early complications in a renal transplant or a liver transplant, and at the same time to guide the biopsies, any procedures whenever there is a complication. So radiologist has a lot of role, multiple areas, where right from the pre-transplant to post-transplant and long-term follow-up imaging, and the radiologist has a key role to play. And these are the publications we have done in recent times related to the liver as well as the renal transplant, and hoping for greater academic collaboration between the International Society of Radiology, the ISR, the IRIA, the Indian Society, and even the Egyptian Society of Radiology and Nuclear Medicine. Namaste from India. Thank you.
Thank you, Professor. First, before I ask, I have a few questions. Anybody in the floor would like to have a question? Well, actually, I would like to thank you for this detailed presentation on organ transplant, because I consider organ transplant to be a community by itself. Through all, it's a big family working together to get this patient to return back to his good quality of life.
Yes, sir.
But I would like to ask you concerning liver transplant. You mentioned concerning the donor that in your protocol you do first CT assessment, attenuation value, and then if it's a bit high, you do MRI, fat fraction, and if it's still high, you do a liver biopsy.
Yes, yes.
So if a donor CT value is good and the MRI value is good, you don't do a biopsy.
No.
Okay, this is very interesting.
Yes.
And because very few centers in the world, we do a lot of living donor here in Egypt.
Okay.
Okay, we've reached more than 4,000 cases now in Egypt. We don't do cadaveric, but we still up till now do liver biopsy. So this is a very, we want to go to the stage of stop doing liver biopsy. And another thing, did you ever try to implement ultrasound assessment of fat in the liver, like UDFF, ultrasound fat fraction, UGAP? Did you ever consider that?
No, actually, ultrasound was never tried as a modality for liver fat assessment. Only initially it was difficult for surgeons to avoid biopsy, as you also mentioned, but with time they also agreed, and in very few patients biopsy is done, but we have not tried ultrasound at all.
Why am I saying this? Because there are cases, CT and MRI don't give you a cut-off value of fat infiltration. They give you an average. Did you ever face cases with small for size graft due to fat infiltration that is not clear, or you did not face that? post-operative small for size graft.
Okay, for a follow-up assessment, graft assessment.
Yes. You see the graft is weight,
Yeah.
GRWR, and then after transplant, if the fat is a bit high, then the graft, the actual functioning hepatocytes is less. So in the end, it's considered a small for size graft, small functioning cells inside the graft. Did you ever face that?
So what we usually do is, if the ratio is favorable, if the ratio is not favorable, then it is becomes a contraindication. Ratio is not more than 0.8, so we don't never go below 0.8 ratio.
No, I mean, are there cases that you did transplant without biopsy, with no biopsy, and then the graft had fat, had a lot of
No,
fat?
we have not seen any such case, thankfully.
This is my question. Okay, thank you. Thank you very much.
Thank you, sir.
There is a question.
When you evaluate for biliary anatomy for donors, do you do MRCP with gadolinium?
No, we only do a plain MRI without any contrast.
So the definition of all the biliary radicals, particular segment 4, it's fine on MRCP with your MRCP? We do a CTA, we do MRCP with Eovist, gadolinium. We don't do a standard ERCP in our donors.
And actually, in our setup, we don't even use secretin or any agents. Only a plain MRCP is done.
Only plain. But that's after he's open. Okay, thank you so much.
Yes, sir.
Yes, thank you, Nitin, for the well-illustrated presentation. I have a question about the post-renal transplant functional MR imaging. I noticed that you mainly depend on bold imaging. Do you have experience with other like ASL or IVIM?
No, we have not tested ASL or IVM. We have only done this. We are only using this bold as well as diffusion on a routine basis, but not using ASL right now. Though it is a good option because it is completely without any contrast, so we should be doing it in future maybe.
Thank you.
But does this cancel the possibility of a kidney biopsy, a renal biopsy from the graft for fear of rejection?
Pardon?
Meaning that if the imaging is suspicious, do you still take a kidney biopsy? Renal biopsy from the graft?
Yeah, renal biopsy is done more readily whenever there is a confusion between ATN versus acute tubular necrosis or acute rejection, then renal biopsy threshold is low. So we go and do renal biopsies more frequently than we do for a liver biopsy.
Thank you. Thank you, Professor.
Thank you, sir.
So now this session is finished. I would like to